Morning, everyone. With protocol being established, I would like to thank the organizers of this event for giving me the opportunity to speak to you all today. I tend to wear many hats, and today I'm wearing a few of them. I'm a researcher as a Vital Strategies Fellow, a public health advocate, a young person from the Caribbean, and I'm extremely honored to be a member of the Global Mental Health Action Network. Non-communicable diseases and mental health are inextricably linked, and I'm glad that this upcoming high-level meeting acknowledges this connection. They share some of the same challenges and solutions. However, there are some unique aspects with mental health that require special attention. This high-level meeting is a significant opportunity to secure progressive commitments to deliver high-quality, rights-based, person-centered mental health services, which are integrated into primary and community-based care. As a young advocate, I know firsthand that authentic progress begins when we invest in people-powered responses, especially those from youth and those with lived experiences. Not just engagement, but full, authentic integration. And I think me being here today is a good example of this, and we need more of it. This means co-creating policies with communities that they're intended to impact. And this will only make more adaptable and resilient policies and legislation. This is especially important within the realm of mental health, as this co-creation actually decreases stigma. It is important that we formalize social participation by elevating lived expertise, which is strengthened by governance, as affirmed by the recent World Health Assembly resolution on the social participation for health. Both NCDs and mental health are profoundly shaped by the circumstances in which we are born, grow up, work, live, and age. But I cannot make a statement here today without addressing the elephant in the room, the impact of harmful industries. Unhealthy food environments, aggressive marketing of ultra-processed products, tobacco use, alcohol use, and digital platforms that amplify harmful messages all shape our health outcomes, including mental health, as I've seen in my own research. To tackle these determinants, we must enact and enforce policies that tax and restrict unhealthy products, require clear front-of-package warning labels, restrict marketing to children, and regulate industries through conflict of interest safeguards. More than 1 in 7 adolescents are diagnosed with a mental health condition. We need to address poverty, family dysfunction, sustainable substance abuse, misuse of social media, and all of which are key drivers to poor mental well-being of our children and youth. Despite a slow decline in suicide rates in general, the number of young people being lost to suicide is actually growing. A young person today is actually more likely to die by suicide than the previous high-level meeting. Suicide and suicide attempts remain criminal offenses in 25 countries, and this needs to be changed immediately. We should be helping persons at their lowest, not punishing them. Every country should have a suicide prevention plan based on WHO's Live Life approach. We need to strengthen primary care to integrate NCDs and mental health screening and services, decentralizing mental health care away from long-stay institutions to communities, expanding youth-friendly services, and bolstering the health workforce to ensure that essential care is accessible to all, and all of these are non-negotiable strategies. Climate change is also affecting levels of most NCDs and mental health conditions, including PTSD, anxiety, and depression. Having climate-resilient health systems is crucial, especially in small island developing states where I'm from, live, and work. As a researcher, I know that robust data and sustainable financing underpin accountability and innovation. We need longitudinal surveillance systems to integrate mental health and NCD indicators, which are co-designed with civil society to monitor progress and spotlight inequities. Sustainable financing must be used for service delivery, research implementation science, social determinants, and youth-led solutions to ensure that wealth is never a barrier to care. Your Excellencies, my dear colleagues, this upcoming high-level meeting on NCDs and mental health presents a historic opportunity. I urge us to seize it by championing integrated, rights-based, and person-centered approaches to bridge the silos between physical and mental health. I wholeheartedly believe that together we can transform this political declaration into tangible progress. Let us create healthier environments, stronger communities, and a generation that thrives. The time to lead is now. All of our futures depend on it. Thank you.
Thank you very much, Mr. Moderator. Distinguished member states representatives, ladies and gentlemen, good morning. It is an honor of mine indeed to be on this panel today to tell you the story of StrongMinds and how we've been able to democratize therapy and the care for people with depression. StrongMinds democratizes access to mental health care for people with depression globally. We bring high-quality, evidence-based, first-line depression treatment and suicide prevention to people in their own communities. We do this in Uganda, in Zambia, in Kenya, Malawi, and Ethiopia. And this month, we will be celebrating treating 1 million people for depression since 2013. 3/4 of these come out of depression, come out of care depression-free, assure testament that community-based care can be helpful in detecting and treating early, which is quite cheaper and cost-effective. This allows them to return to regular daily life functions like going to work or going to school in the case of children. With years of working with governments in Africa, StrongMinds has learned some important lessons, and I beg to submit these lessons. Number one, moving towards the institutionalized and decentralized care works very well. And secondly, our clients do not lead single sector lives. And our policy and programmatic approaches cannot be single sector either. A multi-sectoral approach to mental health is a viable option. And to clarify this, I would like to expand this just in 2 areas. Firstly, decentralizing care away from the institutions towards the community is critical in bringing mental health care to people in their community. At StrongMinds, we've shown that we can deliver mental health care that is effective and cost-efficient through lay providers and people with lived experiences. Together with the Ministry of Health in Uganda, we have trained and supported community health workers to treat about 350,000 Ugandans for depression. Community health workers can play a critical role in decentralizing mental health care, especially in middle and low-income countries. And their fair remuneration must be also part of what the nations consider as their mental health priorities. And secondly, mental health care has to reach beyond the health sector. And StrongMinds has continued to build partnerships across a number of sectors, but for the benefit of this meeting, I'll share the 3 examples that stand out. To reach adolescents and children, we collaborate with the Ministry of Education to train teachers, to identify students struggling with depression, and deliver therapy to them at school because this is where they spend their biggest time of life. Through our partnership with the Uganda Prison Services, we have been able to provide care to about 18,000 prisoners with depression treatment by training other inmates and people with lived experience to facilitate our therapy model. In climate change-affected communities in Uganda, many people are trapped in the vicious cycle of food insecurity and depression. And with treatment Our clients develop psychological resilience, the ability to adapt to the face of continuing environmental changes. And for example, in the case of Uganda, a district in Kotido district is one of the places where StrongMinds works, and the pastoral communities there struggle with extreme weather conditions leading to numerous cattle deaths and crop failures. Of course, these circumstances trigger depression and climate anxiety. Through our group therapy sessions, we've seen clients develop stronger coping mechanisms for daily stressors of climate change, such as sharing food during times of scarcity and offering free labor to one another to cultivate more land in the seasons. For a mother in Kotido district, the StrongMinds group talk therapy helps her to find practical solutions from peers and arms her with essential life skills to remain free from depression and climate anxiety amidst recurring effects of climate change. In summary, ladies and gentlemen, deinstitutionalizing mental health care and collaborating across sectors leads to better mental health and well-being outcomes. We have a unique opportunity in this room today to create norms and new norms specifically that place good mental health and well-being at the center of our lives and our work. I thank you, and let's do it. Happy Mental Health Awareness Month, because this is the month of May. Thank you.
Colleagues and fellow advocates, I am Dr. Spirit, Executive Director of T2S Cares and proud member of the Global Mental Health Action Network, representing 6,000 members from 170 countries through 3,500 organizations. I want to drive home the point today that mental health is not an abstract concept or an issue secondary to other health concerns. Mental health is intrinsic to every health issue, every patient interaction, and every non-communicable disease intervention, and determines the quality of the lives in which we all live. Each one of us here today has mental health, but sadly, not even us all experience mental wellness. Recognizing that those closest to the challenges hold the deepest understanding of the solutions, yet typically lack the resources to implement change, our strategies must therefore deliberately integrate mental health, as it influences and is influenced by every NCD we address. Firstly, we must urgently work to decriminalize suicide, including doing away with language like committed suicide, which criminalizes a person losing their battle to the anguish and pain that they're suffering, and only deepens isolation and discourages seeking the treatment necessary to survive their illness. Integrating mental health support, including the actual mental health professionals trained to provide this care directly into primary health care, can provide critical lifelines and reduce stigma to save lives. Secondly, we must focus on the mental wellness of children and youth. The ACEs that our children are experiencing are leaving them to perpetuate lifelong health issues. Ensuring early, comprehensive mental health interventions will foster resilient leaders capable of addressing both NCDs and broader societal changes effectively. Thirdly, let us accelerate the shift away from institutional care towards community-based mental health support. Community-driven holistic care solutions honor individual dignity and lived experiences, empowering communities to create culturally sensitive and effective health models integrated into NCD health strategies. And finally, addressing social and commercial determinants of mental health must be central to our NCD responses. Anxiety and depression are natural, treatable responses to hardships like poverty, systemic injustice, and harmful commercial practices. Tackling these root issues through multi-sectoral collaboration can significantly improve global health outcomes, reducing health disparities, and enhancing overall health and economic stability. Mental health is the foundation to resilient communities, thriving economies, and effective NCD management. I urge you today to commit to integrating mental wellness into every facet of your healthcare initiatives and policies. Thank you.
My name is Muskan Lamba, and I'm representing the Global Mental Health Action Network today as a youth representative. I come from Delhi in India, where summer temperatures are already approaching 50 degrees Celsius. This matters deeply to any conversation on NCDs and mental health because heat stress is unjustly felt across low and middle income countries and is increasingly a driver of both physical and psychological harm. Mental health is not a silo. It intersects with climate, poverty, gender, education. In 2025, it is not radical but necessary to say mental health is the thread running through all sustainable development goals and whichever goals may come next. In my community, it is no surprise to hear of at least one person in every family living with an NCD or mental health condition or having lost someone to one. In my case, it has been 3 of my grandparents to cancer, a beloved uncle, and my 20-year-old friend Sam to suicide. It is the grief, the love, and the meaning of these losses that bring me here today to speak about mental health. The lack of global solidarity around mental distress, despite it being a major cross-border reality, is heavy. I have worked closely with young people experiencing climate anxiety, displacement, discrimination, burnout, loss, helplessness, and grief, quietly and often alone, because in many parts of South Asia, mental health is still a luxury or a shame. But what I've learned is that people are not broken, systems are. India has the world's largest youth population and one of the highest suicide rates, accounting for 40% of global suicides among women and a quarter among men globally. A child or young adult in my country grows up with layered insecurities, climate chaos, joblessness, digital overwhelm, and unspoken generational pain. Yet 83% of those needing mental health support don't receive it. And while statistics help us understand scale, mental health is also about dignity, about every person's right to live, to be heard, and to heal. I deeply believe that the world is the sum of how the majority of people feel and operate. If so many young people around the world are more lost than ever, it is a deep crisis for the present and the future. I've seen what happens when mental health is embedded in schools, peer groups, care circles, open dialogue spaces. Young people begin to heal together, but we cannot keep depending on unpaid labor and underfunded networks to carry this work. Mental health must then be seen not as charity, but as a structure, a human gift and resource. So today, I urge member states to decriminalize suicide and reform services by transitioning from institutional models to rights-based, community-rooted, and culturally inspired mental health care, integrate preventative mental health across systems, invest in the mental health workforce, including, importantly, peer supporters, youth, and caregivers, strengthen data, accountability, and lived experience leadership, especially from the LMICs, ensure sustainable financing for integrated mental health services within universal health coverage. We waited long enough for mental health to matter, and I hope that September's high-level meeting is a turning point where we stop just promising care and start practicing it. Thank you.
Excellencies, honored guests. My name is Dr. Kim Baranowski, and I represent the American Psychological Association, which has consultative status with ECOSOC and is associated with the DGC. APA is the leading scientific and professional organization representing psychology in the United States, with more than 173,000 domestic and international members. Our mission is to promote the advancement, communication, and application of psychological science and knowledge to benefit society and improve lives. APA also serves as the Secretariat for the Global Psychology Alliance, a coalition of more than 80 national, regional, and international associations, institutions, and training programs who jointly apply psychology to address global challenges. Psychology is a diverse discipline firmly grounded in science, with boundless applications to support the achievement of the SDGs. As a psychologist, clinician, and researcher, I have witnessed firsthand how structural forces shape the mental health and well-being of communities. Specifically, in my work with individuals exposed to human rights violations, I document evidence of the psychological impacts of persecution experienced by people in migration who have endured violence and social exclusion, have been forced to flee their homes, their careers, and their communities to ensure their survival. and who now, in their host countries, often experience significant barriers to accessing culturally responsive, trauma-informed, and community-based mental health care to support their recovery from human rights abuses. My experience clearly shows that mental health and psychosocial support is vital for the success of immigrant communities to rebuild their lives, as well as their future health and well-being, ensuring their full economic, social, and political participation. We strongly support the centering of mental health in the political declaration through an integrated, holistic, and human rights lens. We recommend considering mental health and NCDs in the context of social determinants and encourage a population health approach, as an individual's well-being cannot be considered in isolation from their relationships, communities, and societies. We also advocate for centering the importance of child and youth mental health, suicide prevention and decriminalization, and deinstitutionalization, as well as the meaningful integration of lived experience expertise in both design and implementation of system reform. We encourage member states to incorporate these topics, as well as others highlighted in the Global Mental Health Action Network's policy brief. Thank you.
Madam Chair. The Wellcome Trust is a global charitable foundation that supports science to solve the urgent health challenges facing everyone. We're the largest non-governmental funder of mental health science globally. Although effective interventions exist that can help people live fulfilling lives, insufficient investment, regulatory barriers, and infrastructure gaps mean that not everyone who needs them can access them. The mental health treatment gap is particularly stark in low and middle-income countries, where over 75% of people lack access to essential mental health care, including medication. Through the research Wellcome funds, we're seeing a revolution in mental health science. Innovative pharmacological, psychosocial, and digital interventions are transforming how we can treat mental health problems globally. This high-level meeting is an opportunity for member states to commit to invest in mental health and to make interventions accessible to all. To achieve this, we have 4 calls to action for member states. First, invest in mental health. We urge member states to close the treatment gap by committing to invest in mental health and integrating it into universal health coverage. In many countries, this means system reform to embed mental health into primary care and community-based services, tailoring health provision to reflect local need, and grounding all efforts in evidence and involving people with lived experience. Second, align external funding with national plans. We encourage donor governments to strengthen government-led national plans in low middle-income countries by financially supporting domestic priorities for scaling mental health interventions through multilateral and bilateral channels. Third, strengthen the regulation of mental health treatments. Member states must continue to strengthen national and regional regulatory efforts to expand access to existing medications and pave the way for adopting new and effective medications as they become available. New digital health interventions offer cost-effective methods to address unmet mental health needs. We encourage member states to collaborate to develop robust regulatory guidance and frameworks for digital mental health interventions, including those that use artificial intelligence. Fourth, put lived experience experts at the heart of policy and planning. This will build trust, relevance, and impact. The next wave of mental health solutions is within reach. With coordinated leadership, member states can take vital steps in this high-level meeting to ensure the world is ready to deliver mental health solutions equitably and at scale.
Buenas tardes. Gracias por la oportunidad de contribuir. Mi nombre es Lucero Andaluz, represento a De-Mentes, organización peruana dedicada a la promoción y prevención en salud mental, y a The Global Mental Health Action Network, red que reúne a más de 6.000 activistas de salud mental de más de 170 países. Cuando tenía 8 años, mi hermano Gonzalo fue diagnosticado con esquizofrenia. Él tenía solo 14 años en ese momento. Esta fue y sigue siendo una experiencia sumamente desafiante y transformadora. En primer lugar para él, por supuesto, pero también para mí y para mis padres como sus cuidadores. Desde muy temprana edad pude ver las falencias de los sistemas de salud mental y su profundo impacto en el camino hacia la recuperación. Estar aquí hoy es un enorme privilegio. Es raro que la salud mental esté en el centro de una reunión de alto nivel de la ONU. Es vital que usemos esta oportunidad para acelerar el progreso en salud mental mediante su integración con las enfermedades no transmisibles, para que millones de personas como mi hermano puedan vivir una vida plena y encontrar el apoyo adecuado cuando lo necesiten. Dado el muy bajo nivel de cobertura de los servicios de salud mental en todo el mundo, incluido mi país, debemos asegurar nuevos compromisos que permitan ofrecer servicios de alta calidad desde un enfoque de derechos y centrados en las personas, integrados en la atención primaria, secundaria y terciaria, así como en los esfuerzos de prevención y de tratamiento. Considerando que la salud mental está profundamente influenciada por las circunstancias en las que nacemos, crecemos, trabajamos, vivimos y envejecemos, la salud mental tiene una conexión bidireccional con el desarrollo sostenible. Necesitamos que los Estados miembros adopten estrategias multisectoriales que consideren los determinantes sociales y comerciales subyacentes de la salud mental. Necesitamos también asegurar el involucramiento significativo de personas con experiencias vividas en el diseño y despliegue de las políticas e intervenciones de salud y salud mental. Además, les pedimos asegurar un cambio sistemático en el enfoque de atención, erradicando la institucionalización y la sobremedicalización para avanzar hacia la prevención, la intervención temprana y la implementación de servicios de salud mental comunitarios. Estas alternativas no solo son más humanas, sino que han demostrado ser mucho más costo eficientes. Es momento de actuar y de liderar el cambio hacia servicios de salud mental integrales que protejan los derechos de todas las personas, más humanos, más empáticos, más inclusivos y libres de estigma. No hay salud sin salud mental y, sobre todo, no hay desarrollo sostenible sin salud mental. Contamos con ustedes. Gracias.
Thank you, Chair, constituents and co-creators. Good afternoon. I'm Matthew Jackman. I'm the founder of the Australian Centre for Lived Experience and a member of the Global Mental Health Action Network. I'm speaking today as someone with a lived experience of what we're here to change. I was removed from my mother by child protection due to mental health issues, and as a consequence, she died at age 28 whilst I was in foster care. I was 9 years of age at that time. From that moment, I became the primary carer for my younger siblings, raising them in poverty through school, in a home marked by family violence, addiction, stigma, and very limited access to community mental health support. I ended up institutionalised myself for over a year, over 9 hospitalisations, often unaddressing my needs, my preferences and human rights. My distress was never individual or biomedical or about a broken brain, and it was and is deeply social, political and structural. And I use the example of also experiencing homophobia and gender-based discrimination as I came out as queer and non-binary, further compounding my distress, but also to honour my mother's spirit within me as two-spirit. This is why I urge Member States to politically declare an equitable investment in care away from harmful institutions through a deinstitutional approach, care that doesn't pathologise and medicalise human suffering, grief, trauma, poverty, sexuality and all those intersectionalities of equity. We need services that are rights-based, peer-led, culturally grounded, community-based, person-centred, where healing is not done to us, but led by us, drawing on our collective lived experience wisdom. Mental health systems must move away from coercion, eliminate involuntary and forced treatment, and move toward connection, consent and collective care. Multisectoral governments must mean more than policy alignment. It must mean sharing power, as we've heard, with those most affected and impacted, those of us with lived and living experience. Member States must also resource and remunerate lived experience leadership as expertise, not as a gesture, but as a rights-based, economic and ethical imperative. Lived experience is expertise. It's a discipline and it's a social movement in our intersecting spaces. So let us build humane, integrated systems that honour pain and survival and trust people like us to co-lead the way forward, as those closest to the problems are often those closest to the solutions in putting people first over profit. We don't ask for a seat at your table, we invite you to co-create a new one. And as for harmful commercial determinant industries, our mental health is not for sale. It's time we all take a stand. Thank you.
Greetings, dear Excellencies and Honorable Delegates. My name is Benny Prawira, founder of Into the Light Indonesia, the first youth-based suicide prevention community in Indonesia. I've been working since 2013 alongside with youths with lived experience to prevent suicide. One of the remarkable programs that we have been doing since 12 years ago is our youth peer support program, equipping them with the capacity to detect and intervene mental illness and suicide. Thousands of college and school students can observe how their peer shoulders straighten, and for the very first days for the first time in their a smile might appear after they have gone through dark times in their life. Once they support their displaced peers as a result of this peer support training. However, there are times that further support needed, yet hardly available in the community and the system. Some of these trained peer supporters shocked to find out that their peers who usually live far away from their hometown to study and happen to have injured themselves due to active suicidal ideation still had to deal with the fact that the injury is not covered by the national health insurance. It has another wound atop a 16 pain, as now these young people had to lie to gain more money from their parents to treat the injury. These problems extend far beyond Indonesia's border. In 25 countries worldwide, suicide attempts are merely excluded from health coverage, they are criminalized. Across these countries, the eyes of the young suicide attempt survivors and their families reflect not only the professional support they need, but raw fear of legal consequences. This also hinders data collection, holding us back from developing effective national strategies. A different reality is possible, where distressed youth and other marginalized groups receive the community and healthcare they need, and family members receive guidance rather than blame. To achieve this, I have 3 points for member states to politically declare. 1. Decriminalize suicide attempts and include suicide-related injuries in national health coverage. Rather than documenting criminal charges and medical bills, record scans instead be used for affordable care plans. May I also emphasize to member states that in some countries, to decriminalize also means to decolonize, since the criminalization law stems from the history of colonial legacy. Secondly, adopt the WHO Live Life framework for a whole society approach, ensuring every country has their national suicide prevention strategy in place so that everyone is aware of their essential role in preventing suicide. And third, recognize the rights to meaningful engagement of people with lived experience, particularly youth, and address the barriers to participation, particularly for those people who live with marginalized identities. So, through centering this voice,
Thank you. Distinguished delegates, my name is Tabitha. I am proudly standing here today as an advocate for the American Heart Association and its American Stroke Association division. From the moment I was born with a hole in my heart, my life has been filled with both challenges and triumphs of those living with heart disease. Surviving a stroke at the age of 28 deepened my understanding and appreciation of the urgency of this complex global health crisis. Heart disease, stroke, and other forms of cardiovascular disease remain the leading cause of death worldwide, claiming more than 2 million lives each year. Yet it continues to be under-recognized, particularly when it comes to women. CVD kills 1 in 3 women, but too few women recognize that this is their greatest health threat until it is too late. And now heart disease is striking younger populations too. In 2019 alone, an estimated 3.8 million young people from 15 to 39 were newly diagnosed with cardiovascular disease, and this trend is absolutely unacceptable and preventable. That's why we're here urging every country to adopt a national cardiovascular action plan. As many as 80% of heart attacks and strokes are preventable, and yet fewer than 7% of countries have standalone plans to tackle heart disease and stroke head-on. Stroke, a major form of CVD, affects 12 million people annually, and half of those strokes are fatal. Many survivors face long-term disabilities, and 38% of stroke survivors are of working age. In collaboration with the new Global Stroke Action Coalition, we urge governments to prioritize stroke within national CD strategies. We also echo the call of the NCD Alliance Time to Lead campaign. We must also recognize and address the interconnection of cardiovascular, kidney, and metabolic diseases. Addressing these conditions together, rather than in silos, will lead to improved prevention, better health outcomes, lower costs, and longer, healthier lives. As someone who has lived through the realities of CVD and stroke, I cannot stress enough the importance of inclusive policies that prioritize the unique health needs of women and youth globally. Our stories, our struggles, including mental health, and our insights must help shape the future of healthy systems everywhere. Together, we can build a healthier future for all. Thank you.
Excellencies and distinguished guests, my name is Dr. Hamdi Issa. I'm speaking on behalf of United for Global Mental Health and as a representative of the Global Mental Health Action Network that brings together 6,000 advocates from 170 countries. As mental health advocates, we recognize that the UN high-level meeting on NCDs and mental health presents a unique opportunity for member states to accelerate global progress on mental health. The complex and bidirectional relationship between NCDs and mental health does not warrant vertical and silo interventions. That is not sustainable. Instead, we urge member states to consider the following. First, it is critical governments shift health systems from the inequitable one-size-fits-all approach towards models of people-centered care that integrate mental health and NCDs in primary care settings, making services accessible where and when people need it most. This is the fastest way to closing the mental health and NCD treatment gap. Second, the ambition for integrated people-centered mental health care relies on adequate funding, and yet annually there is a monumental $200 billion finance gap for mental health. This is too big of a gap to ignore. To sustainably narrow this gap, domestic resources need to be increased. For high-income countries, this would include allocating at least 10%, and for low-mid-income countries, at least 5% of health budgets to mental health. But in the parts of our world with fragile economies, domestic resources are not enough, and therefore external donors can and should catalytically fill these gaps. Currently, 2/3 of mental health budgets go towards institutional-based care that are historically associated with human rights abuses. To advance a rights-based approach to mental health care, countries should develop a national plan for gradually shifting the locus of care and resources from costly, long-stay institutions towards cost-effective, community-based models of care. Third, protecting youth mental health. Globally, young people are facing a generational mental health crisis. 50% of mental health conditions begin by age 18, and youth suicide rates are rising. Yet, the rapidly evolving social and economic landscapes in which we live and thrive demands more from young people than ever before. Despite these systemic barriers, young people continue to rise as leaders. Our health systems should be malleable to their voices and the voices of people with lived experience. Access to age-appropriate mental health services are not optional. Member states must prioritize early intervention and early treatment, tailored to young people and readily available where young people spend most of their time. And lastly, we are calling for collective appreciation that one's mental health is shaped by social and commercial determinants. And we urge member states to recognize that an absence of mental health in all policies that consider the adverse social and economic conditions individuals operate in will be a disservice to society's most vulnerable. Thank you.
Hello, this is Eshetu from the African Population and Health Research Center. I'm a research scientist, and APHRC is an Afrocentric organization working across Africa on mental health and NCDs. So, ladies and gentlemen, from my personal research experience in the field of mental health in Africa, I have observed and witnessed that mental health is often not prioritized even at the policy level in several African countries. And in those nations that do not have policies in place, these commitments frequently remain unfulfilled. Mental health issues are consistently the lowest priority when it comes to actionable solutions. For example, evidence indicates that mental health budget in low and middle income countries is less than 1% of the total annual health budget, despite the disproportionately high burden of mental health conditions. If we do not act on mental health today, the future of low and middle income countries particularly in Africa, is likely to worsen. This is due to the increasing magnitude of conflict, poverty, migration, youth unemployment, epidemics, weak health systems, food insecurity, and climate crisis. Women, adolescents, and children in rural Africa often lack mental health literacy and may be required to travel hundreds of kilometers to access basic mental health services, if such services are available at all. They frequently endure long waits, sometimes for hours or even days, due to severe shortage of mental health professionals. Additionally, they may incur catastrophic out-of-pocket expenses for treatment. Mental health medications are not included in the essential medicine list, making them luxury that is often unavailable in ordinary pharmacies across many low and middle-income countries in Africa. Importing these medications to Africa presents numerous challenges, including logistic issues and financial constraints. Finally, I envision a future where we can proudly tell to our children and future generations that we played a significant role in the history of creating tangible, context-specific, human-centered, and equitable mental health initiatives in our countries and around the globe. There can never be health without mental health. Ubuntu.
My name is Maria Davina O'Brien. I'm a director of Mindwise Project, a member of the WHO Symposium for Meaningful Engagement Steering Committee, and a member of the Global Mental Health Action Network and National Committee of MHPSS for Trinidad and Tobago. And most of all, I'm a person with the lived experience of NCDs and mental health crisis. I am here as a voice for small island developing states, as a suicide prevention activist, and a Trinbagonian woman with the lived experience of cancer, domestic violence, and addiction. And I want to ask you all right now, are you in pain? Where does it hurt? How many of us have heard this or asked this when trying to get a picture of another's pain? The story of untreated and unmanaged pain is a determinant for mental health and resulting physical health issues that connects us all, the thread running through all of us. It has been 14 years since I have been here in the United States. On September 24, 2011, in the heart of Baltimore, I found the body of Michael, my partner, in the alley below our 8th-floor apartment. His suicide shook me to the very core of my being. I didn't understand how I could miss it. At that moment, I can truly say I had never even thought about suicide as something that affected my world. How many of us do really, until it does? What I discovered was that every 40 seconds, suicide is affecting all of our worlds. At that time, it was called a global epidemic. I discovered that Michael's story was not uncommon. 80% of suicides all around the world are men and boys. In my own country, during the pandemic, the youngest life lost to suicide was a 7-year-old boy. We also saw a rise from 80% to 88% in 2 years. Suicide takes place when pain exceeds resources for coping with pain. How we address suicide and the decriminalization of suicide is a true litmus test of our emergency and crisis readiness and an indicator of accessibility to community resources and effectiveness of those services. What is this story telling us? We are not just here to advocate for ourselves. We are here to advocate for you, all of you in this room and all of you not in this room watching us right now. I have 3 simple and achievable asks for you and all of us as we build towards the UNG in September. The first is, don't start from scratch. Use the evidence-based positions and docs you have already received from the groups represented here and build around them. They have been built with over 6,000 lived experience experts all over the world. And as one of those persons, these organizations have earned my trust and they deserve yours as well. The second is to update laws and systems to decriminalize and prevent suicide. These are realistic and easy wins through a lens that is easy to measure and scale if it is successful, creating a powerful, scalable system. Suicide is preventable. Let us act now. Walk the talk. Take one step forward for all mankind and host national consultations with your youth and lived experience persons. Thank you.
Good evening. I'm Monica Arora, President of the NCD Alliance, which is co-chair of the WHO Civil Society Working Group. This working group on NCDs represents over 30 organizations collaborating to strengthen the global response to NCDs and mental health conditions. The UN Secretary General's progress report highlighted that the global response has been inadequate. Urgent action is needed. Therefore, we call for the HLM declaration to include the following elements. First, enhancing governance. Ensure meaningful participation by individuals across all age groups and communities living with and affected by NCDs and mental health conditions, and health personnel in all aspects of governance, decision-making, and delivery through social participation mechanisms. Build multi-sector collaborations and uphold the commitment made at the 2018 HLM to promote policy coherence and coordination through whole-of-government and health-in-all policy approaches delivered through a national multi-sectoral coordination mechanism. In doing so, governments must strengthen public health governance by establishing clear, enforceable safeguards to prioritize public health over commercial interests and prevent conflict of interests and undue influence from health-harming industries. In line with the Bridgetown Declaration, we specifically urge governments to ensure that health-promoting policies are not undermined by trade or investment agreements. Second, strengthening health systems. Strengthen community and primary health care that integrates NCDs and deinstitutionalizes mental health services and provide access to person-centered specialized care. Integrate NCDs and mental health into universal health coverage and reverse the rising trend in catastrophic out-of-pocket expenditures. Invest in the health workforce to enhance holistic and quality care, prevent shortages, enhance working conditions, and address the causes of brain drain. Increase equitable access to care by strengthening and harmonizing regulatory mechanisms, improve regional and local production and procurement capabilities, developing pricing policies, facilitating technology transfer by addressing intellectual property and financing barriers. Increasing the sustainability of health system, ensuring they are climate resilient and prepared for current and future environmental health challenges. Third is creating health-promoting environments, accelerating implementation of WHO best buys, the evidence-based, cost-effective measures that reduce exposure to the risk factors and commit to addressing fossil fuel-driven air pollution and increasing population levels of physical activity. Address social, environmental, economic, and commercial determinants that are contributing to the burden. Promote health education campaigns to educate the public and policymakers, fostering health literacy and reducing stigma. Support capacity development of lived experience experts. Adopt prevention strategies to address suicide, particularly among adolescents for whom suicide is leading cause of death, and repealing discriminatory legislation such as the criminalization of suicidal behaviors. Fourth is building sustainable financing. Commit to a set of global financing targets for NCDs and mental health investments. Implement innovative financing strategies, including health taxes that offer a triple win. The fifth is strengthening data and surveillance. Strengthen health information systems for routine collection and analysis of data that drive equitable and targeted interventions. Establish robust frameworks for tracking progress involving civil society organizations and communities in monitoring and evaluation process to hold governments accountable. Providing enabling environment for social participation of civil society actors. Lastly, aligning with the NCD Alliance call to lead on NCDs and Kigali Youth Declaration, we urge all governments to commit to resourcing, implementing, and monitoring evidence-based actions to address the risk factors and wider determinants of health, strengthen health systems and health workforce to ensure the best care and outcomes for billions of people affected by NCDs and mental health conditions globally. Thank you.